Greetings from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Myself, Dr. Bharat Gazre, fellow pediatric cardiac intensive care, and my guides are Dr. Kamlesh Taylor and Dr. Suresh Rao, sir. We want to present our experience in the post-operative air leak syndrome management in a case of unilaterally absent pulmonary artery. It was a nightmare experience for us. Unilateral absence of the pulmonary artery is associated with other cardiac or non-cardiac anomalies, and it's a very rare condition. Sometimes it can be present in isolation also. Postoperative management of such complex cardiac conditions can be really tricky, and ALX syndrome is one of such dreaded complications. We are reporting our experience in challenges we faced in managing one of such cases. A 1 month old girl child was presented to us. Uh, she was weighing 2.4 kg. She was a preterm basically, and recently diagnosed and referred to us for the management. So she was diagnosed to have absent right-sided pulmonary artery with a large VSD shunting bidirectionally with severe hypoplastic transverse arch and a large PDA which was again bidirectionally shunting. So after initial stabilization, uh, she underwent aortic arch repair with VSD closures, and we decided to keep some fenestrations in anticipation of the severe pulmonary hypertension. Also, we did the RPA reconstructions using the homologous radial artery graft. Preoperatively, CT scan was confirmed the diagnosis, and there was absent right-sided pulmonary artery, and the lateral lung was hypoplastic and oligemic. The 3D image was again showing the hypoplastic arch and the absence of the right-sided pulmonary artery. So immediately after the surgery, in the immediate post-operative period, the ventilatory setting requirement was very high, with the airway pressures exceeding more than 30. Also, the child was clinically unstable. There was inadequate gas exchange, persistent metabolic acidosis, significant desaturation. The echo confirmed VSD fenestration shunting right to left. So we decided to shift her back to the theater and close the VSD fenestration with the hope that it will increase the saturation and improve the metabolic acidosis and overall condition of the child. So after the closure of fenestrations, we started the inhaled nitric oxide support and shifted the child on the HFOV because the airway pressures were really high and we were not the child was not holding on to the conventional ventilation. So on the HFOV, the gas exchange gradually improved. The PO2, PCO2s, and the lactates came down. So we continued the HFOV in PCICU for next 2 days, and gradually we in the setting initially the FiO2, later the MAP, and then the gradually we shifted on the conventional ventilation. But then the nightmare happened. Just after the 6 hours of the conventional ventilation, after shifting from the HFOV, the child condition suddenly deteriorated, and we found to have that there was a bilateral pneumothorax. So we adjusted the intercostal drains and then shifted back again on the HFOV. The gas exchange was better on HFOV. For next 2 days, again we had to continue the HFOV support, and then gradually we could able to come down on the support. And once the air leak was stopped, we have shifted to conventional ventilation again, and this time we could able to extubate the child with CPAP support. And eventually, after 2 months of the ICU stay, we could able to discharge the child home. In discussion, unilateral absence of the pulmonary artery can be possibly associated with the fragile and immature lung on the contralateral side because of the hypoplasia of that lung. So, to prevent the air leak syndromes to this highly susceptible underdeveloped lung, uh, gentle ventilation with the low tidal volume, low pressure, low inspiratory time, high rate, and a judicious use of positive and expiratory pressure, which can be provided by the HFOE. Uh, this is the key for these patients. This is the pressure volume curve which we get in during the conventional ventilation. At the high volume and high pressure, there is a zone of polytrauma, and at the low volume and low pressure, the zone of atelectasis. So the HFOV functions in this zone of safety in between the two. That's why it is considered to be a safer option as compared to the conventional ventilation, especially in presence of such complex cases. HFO, HFOV can provide adequate gas exchange using extremely low tidal volume and high rate of ventilation, can reduce the risk of air leak syndrome. Mejang et al. Have highlighted the role of HFOV for neonatal air leak syndrome in its preventions. They have studied almost 850 children and found to have HFOV helpful. However, very limited data is published about the use of HFOV for management of air leak syndrome, especially in the cardiac patients. Implications in clinical practice. Complications like air leak syndrome are really troublesome to manage and can contribute significantly to the mortality and morbidity. HFV can be a better mode of ventilation for management of such air leak syndromes. However, we need more data regarding this to form a consensus for managing such complicated cases. Thank you.